This is a new module which I've added, abdominal emergencies, where I'm going to discuss the clinical scenarios. And the reason for me adding this module is that looking at the changing pattern of the exam, where more clinical oriented questions are being asked, I just want you to give you a feel of what it is like to be in the emergency and handle these abdominal emergencies, okay? Now, so in this module, I haven't given options after the questions, right? So I want you to have these things on your tips so that you can not only answer questions in the exam, but you can also manage patients better. Now, this module, invariably, you will have 1 to 2 questions in the INI CET exam focused on abdominal emergencies, either an obstruction or a perforation. And similarly, in NEET, I have seen that at least 1 to 2 questions are there from abdominal emergencies. So do go through this module, especially before the exam. In the last month, this is going to be very high yielding as well. So let's start with the cases. We have a 45-year-old male who undergoes a therapeutic upper GI endoscopy. Now, one thing which I want you to become habitual of is to identify keywords, right? And whenever you're solving these MCQs, get these keywords into your mind, because the sooner you start identifying these keywords, the sooner you can get to the answer. So we have therapeutic upper GI endoscopy for a variceal band ligation. And post the procedure, the patient is complaining of chest pain for which he requires additional painkillers, right? And his vitals are stable. Okay, so he's had a therapeutic endoscopy and post that he is complaining of chest pain. What do you suspect? Right? So what are the things which will come to my mind? The first thing which comes to my mind after a therapeutic endoscopy, patient complaining of chest pain, is a perforation, is an iatrogenic perforation. And if you remember the esophagus module, I have told you that iatrogenic perforations are more common after therapeutic endoscopies as compared to diagnostic endoscopies. It can just be a normal side effect of the procedure. So sometimes band ligation, you can sometimes have chest heaviness. It can just be a side effect of the procedure. That could be one reason. So this is what I suspect, right? Would you like to do any investigations to confirm the diagnosis? Yes, so the patient's vitals are stable. And if I'm suspecting a perforation, vitals are stable, I would like to do a CECT. I would like to do a contrast enhanced CT scan, and that would give me my diagnosis. That would be the investigation of choice if I have to look for a perforation, provided the vitals are stable. If the vitals were not stable, then what would you do? Then I would like to do a contrast study. Just put some contrast, do an X-ray, see if there's spillage happening or not. Fine. So a CT was done in this patient, and you can see here that this is your esophagus, and you can see that there is gas here. You can see all these areas marked. You can see that there is gas and there is some leakage which is happening. So the patient has indeed suffered from an iatrogenic perforation. Patient has suffered from an iatrogenic perforation of the esophagus. Now, quickly, if we go over iatrogenic perforation, you know that iatrogenic perforation, this is going to occur after endoscopy. It is more common after therapeutic endoscopy, more common than diagnostic endoscopy. It is commonly seen in the upper 1/3 of the esophagus. That is where it will be seen. It will be seen in the upper 1/3. Post-intervention, the patient is going to come with a chest pain. The management, diagnosis, I've told you, if the stable vitals, CECT. Management, now if the patient has stable vitals, and if it's a small perf, no sepsis, then the treatment is conservative. Now, conservative treatment would entail here, we would make the patient nil per oral, nothing by mouth, give IV fluids, give IV antibiotics, and control the pain of the patient, and that should suffice here. Okay, but if the vitals are unstable, or if it's a large perforation, or the patient is developing sepsis, then we need to carry out surgery and repair the perforation. Okay. Usually iatrogenic perforations are small and they tend to do well. Okay. You know, the other perforation is Boerhaave syndrome, that is spontaneous esophageal perforation, and that occurs in the lower 1/3 of the esophagus. Okay. Let's look at the next scenario. You have a 35-year-old alcoholic patient who develops sudden chest pain after a bout of retching and vomiting. When he presents to the emergency, his pulse rate is 108 per minute. BP is 100/70. On auscultation, there is decreased air entry on the left side and a crunching sound is heard on auscultating the heart. Okay. Again, so we have an alcoholic patient, sudden onset chest pain after a bout of retching and vomiting. He has tachycardia and left-sided air entry is reduced. The clincher here is the crunching sound on auscultation. You know that this is Hammond's sign. This is Hammond's sign, which is seen in patients with Boerhaave syndrome. Boerhaave is what I was just telling you about, is spontaneous esophageal perforation, which can occur after retching and vomiting. In addition to that, retching and vomiting, there would be chest pain, and these patients are going to have subcutaneous emphysema. So that is the triad of Boerhaave. You would have retching, vomiting, you will have chest pain and subcutaneous emphysema. So two of the things were mentioned here. And Hammond's sign is a crunching sound when the heart when you auscultate the heart. So the diagnosis is Boerhaave. I've told you the clinical signs. Investigations. Now, if it's a stable patient, I would like to do a CECT. If there are unstable vitals, then I would like to do a contrast study. Here. And if nothing is mentioned, like in one of the exams, then you would mark contrast study as the investigation of choice in this patient. Now, these patients develop pneumomediastinum because the esophagus is perforated, and it is perforated to the lower half, left side posterolateral area. So left lower posterolateral area is where it perforates. So you can see here that there is gas present here, there is pneumomediastinum, and there can be a left pleural effusion as well. There can be a left pleural effusion also, which can be seen in these patients, and there will be signs of pneumomediastinum. So management of a patient with Boerhaave syndrome, again, if the patient presents early and there is minimal sepsis, stable vitals, we are going to repair the perforation. But if the patient presents late and there is sepsis present, unstable vitals, then I have to finish surgery quickly. I cannot repair. I don't have that much time. So here what we do, I've already told you in the module, if supposing this is the perforation, I'll quickly cut the perforated area. We take out the proximal end as an esophagostomy in the neck. And I will close the distal end and I will do a gastrostomy for nutrition. And when the patient recovers, then I can anastomose the two ends. This is the management of Boerhaave syndrome. I just told you, where is the perforation? Left posterolateral region. So which thoracotomy would be done? A left posterolateral thoracotomy is the approach when you have to operate a patient with Boerhaave syndrome. This has also been asked in the exam. Okay, let's look at the next scenario now. You have a patient with chronic osteoarthritis. Chronic osteoarthritis. He comes to the emergency with sudden abdominal pain of 6 hours duration. Pain is not getting relieved by the regular painkillers which she takes for her OSA. Right? So she's been regularly taking painkillers, and that's a big hint for us. What do you think a patient who's been taking painkillers? Yes, ulcers can form in them. Correct. So now the pain is not getting relieved by taking those regular painkillers, and the patient has sudden abdominal pain. There is tachycardia, blood pressure is low, the liver dullness is masked. Normally, you know, when you percuss the liver, there is a dull note which you will get. But when will the liver dullness be masked? When you have air inside, right? Correct. So if there's gas inside, then the liver dullness is going to be masked. Okay. So when will you get gas? If there is a perforation and there is abdominal guarding also present. So what is the diagnosis in this patient? The patient has had a peptic ulcer perforation, most likely a peptic ulcer perforation, secondary to consumption of painkillers. Now, are there any other clinical features? Yes, there can be rebound tenderness. Rebound tenderness can be there in these patients. Guarding, rigidity, rebound tenderness can be seen. Investigation, it's a very straightforward investigation. You will do an erect X-ray chest. Erect X-ray chest is going to show you the classical sign which has been asked in so many exams. You will get a gas under diaphragm, right? You will see gas under diaphragm. Also, what has been asked, supposing the patient cannot stand, then what you do? Then you will do a lateral decubitus film. Then you will do a lateral decubitus film. What is the investigation which can pick up even the minutest quantities of air? Then you need to do a CT scan. But if the vitals are unstable, like in this case, you won't do a CT. You will just do an X-ray, right? I have told you this multiple times. Vitals are unstable. No CT, just an X-ray is enough. When you get gas under diaphragm, you know it's a hollow viscous perforation. Any hollow viscous perforation is going to give you gas under diaphragm. An unstable patient, what do you do in such a case? So there was a question in this year's INI CET exam where they'd given a similar question stem and they'd asked a multiple correct answer option. So if you are in the emergency and you encounter such a case, right? So this was like we used to, in one night duty, we used to have at least 3 to 4 perforation cases which we used to encounter. So what do you do in such a case? Number 1, you hydrate the patient, give IV fluids. So put reasonably wide bore cannula, give IV fluids, hydrate. These patients are usually dehydrated. IV fluids need to be given. IV antibiotics need to be given. You make the patient nil per oral, nothing by mouth. Okay, we put in a Ryle's tube as well, but nothing by mouth. IV fluids, IV antibiotics, give the patient painkillers, don't let them suffer in pain. And shift to OT as soon as possible. Shift to operation theatre as soon as possible. And what do we do in the theatre? We are going to do an exploratory laparotomy. We are going to do an exploratory laparotomy. So in this year's INI CET exam, what were the things which they had asked? IV fluids, IV antibiotic, exploratory laparotomy. Out of the 5 options given, you had to pick these 3 options. So this is how we are going to manage such a case. If you have a peptic ulcer perforation, further approach we've discussed. We've discussed the management also. If it's a peptic ulcer perforation, the most common site is the duodenum. Patient had a duodenal perforation, and you know, for a duodenal perforation, we will do an omental patch repair. An omental patch repair, and this is also known as a Graham's patch repair would be carried out in this patient, right? So this was scenario number 2, very, very common scenario of perforation. Scenario number 3, very common scenario of perforation. You all should know about this scenario, okay? Let's look at the next scenario now. You have a 40-year-old male who develops upper abdominal pain after binge drinking, okay? So upper abdominal pain, binge drinking. Pain is localized to the epigastrium. On examination, vitals are stable and abdominal examination is essentially unremarkable. Okay, no signs on abdominal examination. Vitals are stable, just epigastric pain after binge drinking. What do you think? So you have a patient who's been drinking, upper abdominal pain, epigastric pain. What all would you think about? So we will think about pancreatitis. We will think about pancreatitis. Can it again be an ulcer? Could be, but more likely pancreatitis, because pancreatitis, then your abdominal examination is essentially unremarkable except for the pain. So the pain is out of proportion to the clinical signs seen. That is what is written in all standard surgery books, that the pain of pancreatitis is out of proportion to the clinical signs seen. You might not be seeing any clinical signs, but the patient would say, give me more painkillers. Okay. Now, what investigations will we do in this patient? The questions which have been asked, the first or the initial investigations which would be sent out are serum amylase, serum lipase. This would tell us if there is pancreatic inflammation. Amylase and lipase needs to be sent out. And in these patients, so these are the initial investigations which need to be sent out. But if you're suspecting acute pancreatitis, the investigation of choice for acute pancreatitis is going to be a CECT. Is going to be a contrast enhanced CT scan, which would tell us about the pancreatic inflammation and the severity of pancreatic inflammation as well. There is a CT severity index, you know, the Balthazar score. So it will tell us not only if there's pancreatitis, or it will also tell us the CT severity score. So investigation of choice would be CECT here. You know, the CT severity index is the best scoring system to assess the severity of pancreatitis. And if there is pancreatitis, how do we manage this patient further? Again, if you have a patient with pancreatitis, you make the patient initial management would be make the patient nil per oral, give IV fluids, give IV antibiotics. Antibiotics are only given if severe pancreatitis or if there are signs of infection. Or if there are signs of infection, then only we give IV antibiotics. And the IV antibiotic of choice is meropenem here. You'll give painkillers to these patients. Now, what is the most common cause of acute pancreatitis? You know that the most common cause of acute pancreatitis is not alcohol. Most common cause is gallstones. Most common is gallstones. One more thing, and this was a question which was asked last year in the AIIMS exam, was that a patient develops pancreatitis, his jaundice is progressively increasing, and it's been 48 to 72 hours, the jaundice is increasing, and when you do an ultrasound, you see that there are stones in the gallbladder. So it's most likely that a stone has slipped, caused gallstone pancreatitis, and if the patient is still worsening for 72 hours, right? So if it is gallstone pancreatitis and patient is not improving for 48 to 72 hours, then we should do an ERCP in these patients to remove that stone, to decompress the system so that the patient can recover. And always remember that a patient with gallstone pancreatitis, before going home, before discharging the patient from the hospital, should undergo a cholecystectomy so that one more episode does not develop. Right, you have a 38-year-old lady now, next scenario, with a 1-day history of abdominal pain and distension with non-passage of flatus and feces. So all the classical features, all the cardinal features of bowel obstruction, non-passage of flatus and feces, pain and abdominal distension is there. On examination, pulse rate is slightly raised, BP is 100/70. The abdomen is distended with hyperperistaltic bowel sounds, right? So you know that if there is obstruction, right, proximal to the obstruction, the bowel contracts vigorously. I've told you to overcome the obstruction. So I've told you that if there is a dynamic obstruction, that means there is a blockade, the bowel proximal to that contracts vigorously, and that is how you will get hyperperistaltic bowel sounds. Now, patient had an appendicectomy 2 years back. So what is your clinical suspicion? Well, I know for a fact that the patient has bowel obstruction because all the clinical features are there of bowel obstruction. But what is the cause of this bowel obstruction? Can we get a hint from the question? Well, the hint is that the patient had an appendicectomy 2 years back. And if you've had any abdominal surgery, and after any abdominal surgery, if the patient is coming back with bowel obstruction, the first thing which you should think about is adhesive bowel obstruction. Is adhesive bowel obstruction secondary to bowel adhesions? And you know that bowel adhesions are the most common cause of bowel obstruction, right? So that is what you should think about. And these can occur many years after surgery as well. Okay, so I've had when I was in class 7th, that's when I had an appendicectomy, and my cousin in America, around the same time, she also developed appendicitis there. Her appendix ruptured and she also had an appendicectomy. So both of us had an appendicectomy around the same time, but after a year and a half, she developed an episode of bowel obstruction, which was because of adhesions, right? That is why I've kept this scenario, right? So this can occur many years after surgery. Also, these adhesions can become symptomatic. So don't get misled that the surgery was 2 years back. How can the adhesions bother her now? Okay. You know, the initial investigation for bowel obstruction is an X-ray abdomen, erect and supine, and the investigation of choice, I've told you many times, is a CECT. This has been asked umpteen number of times in various exams. Now, erect X-ray, you know, this is an erect X-ray. Erect X-ray is going to show you air fluid levels. You can see air fluid levels. We've discussed that more than 3 air fluid levels are suggestive of bowel obstruction. But air fluid levels will not tell us the site of obstruction. To know the site of obstruction, we need to do a supine film, right? S for site, S for supine. And I've already covered in the module, and Dr. Mayur has also done that. We've covered how the bowel looks, what are the various features of distended bowel. Jejunum has a feathery pattern, ileal loops are featureless, and large bowel loops will have hostrations present in them. Okay. So these are the initial tests which you would do. The investigation of choice would be CECT, right? Now, how do we proceed further in this patient? So patient is put on conservative management. We will do a Ryle's tube insertion. IV fluids are given, nil per oral, and IV antibiotics are given. If you remember your module on bowel obstruction, I've told you that in adhesive obstruction, this is the only dynamic obstruction where conservative management can be tried for 48 to 72 hours. Conservative management for 48 to 72 hours can be tried. Right? Why? Because most of these patients, majority of them respond to conservative treatment, and the more number of surgeries you perform on them, the more adhesions will form in subsequent years, and that is going to create more problem. Okay. So now what has happened is that the patient fails to recover in 72 hours and the distension keeps on increasing with pain and tachycardia. So the conservative trial has failed. Now if the conservative trial has failed, the decision is taken to operate the patient. And when we operate any patient with bowel obstruction, what is the first structure which you would like to see? This was a question which was asked in the AIIMS exam. The first structure which we would like to visualize is the cecum. And why the cecum? Because if the cecum is distended, then it is large bowel obstruction. And if the cecum is collapsed, then we are looking at small bowel obstruction. So cecum is the first structure, and when we do surgery in such a case where there are adhesions, the surgery done is adhesiolysis. But minimal intervention, because the more number of adhesions you break, the more extensive surgery you perform, the more adhesions will form in future. Okay, let's look at the next scenario now. Next scenario is a 10-year-old boy who comes with right iliac fossa pain. So right iliac fossa pain since 1 day, associated with anorexia and vomiting, but there's no fever. There's tachycardia present. There is tenderness in the right iliac fossa. TLC is raised with raised neutrophils. So it's a no-brainer. Such as in a presentation, the first thing which comes to your mind is acute appendicitis. And you know about the Mantrel's or the modified Alvarado score. So if you look here, there is right hypochondrial pain, anorexia, nausea and vomiting. There is tenderness, rebound pain they haven't mentioned, elevated temperature is not there, leukocytosis is there, and shift to the left is there. So you have a patient who's highly likely to have appendicitis according to the clinical scoring as well. Now, what is the investigation of choice to confirm appendicitis? We know that in children, it is an ultrasound, whereas in adults, it is a CECT. Okay. So what do we see here? We will see a blind ending tubular structure. You will see periappendicular fluid, and there is probe tenderness is going to be there as well. When you press with the probe, there will be probe tenderness. So these are the features which we are going to see in these patients with acute appendicitis. More features have been covered by Dr. Mayur in detail, so you can refer to his modules as well. Now, how do we proceed in such a case? Well, the patient would be made NPO. We will give IV fluids, we will give IV antibiotics, and we take up the patient for a surgery. Why I'm repeating these basic things is because this is what they are asking in the exam now. They want to know, you'll make the patient NPO, you will give IV fluids, you will give IV antibiotics. The surgery, of course, which is going to be performed is an appendicectomy. And so many times we have discussed that usually these appendicectomies go to the postgraduate. So the postgraduate takes an intern, goes and does the appendicectomy. You take up the patient, and the patient is taken up for an appendicectomy. But to the surgeon's surprise, what happens is that the appendix is absolutely normal. So if the appendix is normal, how do we proceed in this case? I've discussed this scenario in the module as well. This has been asked a couple of times in the exam. We search, correct, we search the last 2 feet of ileum. We search the last 2 feet of ileum, and what are we searching for? We are searching for a Meckel's diverticulum, right? And an inflamed Meckel's diverticulum, you know Meckel's diverticulum, it is a true diverticulum, antimesenteric border, 2 feet from the ileocecal junction, and an inflamed Meckel's can mimic acute appendicitis. So that's what sometimes you can miss if the appendix is normal. Don't ever close the abdomen. If you see the appendix is normal, search the last 2 feet of ileum. In my post-graduation, 2 cases we picked up this way of Meckel's diverticulitis. One was perforated, one wasn't perforated. And in this case, you can see there's just inflammation. So you carry out a diverticulectomy. If there is a perforation, we do a resection and anastomosis. I remember that case because that was my first resection anastomosis which I got in my second year post-graduation. That was my first independent resection anastomosis. So that's why I fondly remember that case. The next scenario is a 20-year-old male suffering from bipolar disorder, comes with history of abdominal distension and pain since 2 days, associated with non-passage of flatus and feces. So again, the cardinal features of bowel obstruction: abdominal distension is there, non-passage of flatus and feces is there, no episodes of vomiting are there, abdomen is markedly distended, vitals are stable, and digital rectal examination reveals ballooning of the rectum. So whenever there is bowel obstruction, you will see that there is ballooning of the rectum. The rectum gets ballooned if you do a digital rectal examination. We've already discussed the initial investigation for bowel obstruction. So there is bowel obstruction. We are going to do an X-ray abdomen, erect and supine, and anything which is going through your mind. Can you guess the diagnosis by these conditions? Look, the patient is on bipolar disorder patient. So the patient would be on antipsychotic medications, and antipsychotic medications, young male, massive abdominal distension. What do you suspect? You will suspect a volvulus, and X-ray, when X-ray was done, you will see the coffee bean sign, which is seen in sigmoid, volvulus, which is common in patients who are on antipsychotic drugs. Sigmoid volvulus is common. Of course, the investigation of choice is CECT. Now, how do we proceed in this patient? What is the next step in the management? We've done a CT to confirm the diagnosis that there is volvulus. Now, this is a patient where the vitals are stable, and there is no sign of perforation or no sign of peritonitis. So, what is the next step? The next step we've already discussed in the modules. You will do a colonoscopic decompression. If you remember the module, I jokingly told you that when colonoscopy is not available, then an intern is given a flatus tube to pass through. And when you pass through the flatus tube, suddenly large amounts of gas and fecal matter comes out, and the entire room stinks. And, which is why the intern is told you go to an isolated room and do this procedure. But the standard of care would be colonoscopic decompression. But that is not the definitive management. The definitive management is sigmoidectomy, because sigmoidopexy, if you just fix it, has a high recurrence rate. So sigmoidectomy is done in these patients. Okay. Now you have a 2-year-old male child who's been brought to the ER by his mother. So 2-year-old child who's crying inconsolably, and the mother complains that he hasn't passed stool since 24 hours. In addition, there's been 1 episode of bleeding per rectum, according to the mother, and 2 episodes of vomiting. On examination, abdominal distension is present. Right? So again, features of bowel obstruction are there. It's a 2-year-old child and 1 episode of bleeding per rectum. Okay, according to the mother. The mother is very anxious and wants to know what is wrong with her child. Now, bowel obstruction in a child, you know the investigation of choice in children for bowel obstruction is ultrasound. So you tell the mother that, we understand your anxiety, but we need to get a scan done to see what is wrong with your child. So the scan is done, and this is the scan which you get. So in the scan, you can see the 2 signs, the 2 cardinal signs of intussusception. You can see a donut sign and a pseudokidney sign. So you start thinking there is intussusception present in this patient, and you think of the further management which is to be done. So again, you have a child where now intussusception has been diagnosed. The vitals are stable. Right. So, the further management in this patient, we know the child has intussusception. The vitals are stable. There is no sign of peritonitis in this patient. There is no sign of peritonitis. So in such a patient, the age is also of primary intussusception. You're not thinking of any pathological lead point. It's a primary intussusception age, commonly between 6 months to 2 to 3 years. So in this patient, will you do surgery versus non-operative management? So we'll definitely give a trial of non-operative management. And what is the non-operative management? It is a contrast enema. A contrast enema is both diagnostic and therapeutic in intussusception. The sign which you get the claw sign. And because of the pressure of the contrast and the air, the loop can again spring back into position. That this is the intussusception. If I'm going to give contrast or air from here, this loop can spring back into position. So we do a contrast enema in this child. The intussusception resolves. That is confirmed radiologically. Everyone is happy. Mother is also satisfied. But the patient is still kept for observation and is doing well, but on day 2 days later, similar findings develop. Okay, so unfortunately, 2 days later, similar findings. Now the mother is anxious again. Now what is the further management? So that if there is a recurrence or if there is perforation or if it is secondary to pathological lead point, then in these patients, you need to carry out surgery. So now we can't do another trial of non-operative management. Now we need to operate the patient and we need to deal with the conditions. So that was about an intussusception, another scenario which has been asked in the exam. Now you have a 3-week-old male child. The child has been brought to the ER with complaints of multiple episodes of non-bilious vomiting. 3-week male child, non-bilious vomiting, started 2 days back. Child appears to be dehydrated. Blood urea is slightly raised on when you do the investigations. Parents are particularly concerned as this is their first child. So all the hints are there in the question stem. You have a firstborn male child, 3 weeks, non-bilious vomiting, dehydrated. What do you suspect? You are going to suspect an hypertrophic pyloric stenosis in this patient. Hypertrophic pyloric stenosis is what you suspect, correct? What is the best time to examine the child? This is one topic from which questions have been asked in each and every exam, and central institutes just can't get enough of this topic. Even in this year's INI CET, there was a question from this topic. The FMG exam had 2 questions from this topic. So very, very important topic for the exam. Best time to examine the child is when the child is feeding, and when the child is feeding, you will see a palpable olive-shaped lump, and there is visible peristalsis. There is visible peristalsis going from left to right, visible peristalsis, and that would be then followed with vomiting. You know, because the pylorus is hypertrophied, so there will be vomiting. How do you confirm the diagnosis? You know that the investigation of choice to confirm the diagnosis is an ultrasound. And ultrasound, if the length of the pyloric channel is more than 16 millimeters and the thickness of the pyloric muscle is more than 4 millimeters, that's what is going to confirm the diagnosis for you. The other signs, if you do a contrast enema, you can get the mushroom sign, you can get the double or the triple track sign, the diamond sign. These are the other signs which you can get in this condition if you do a contrast. Not an enema, I'm sorry. That was just a slip of tongue. If you do a contrast study, these are the signs which you can get. The typical metabolic abnormality has been asked multiple times. You will get hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Why this develops, I've covered in detail in the module. If you want to see, you can refer to the module for details. Now the child, I told you in the question stem, the child is dehydrated. What is the best fluid to correct this abnormality? The best fluid is 0.45% NS, normal saline, plus dextrose. Please remember, KCl should be added. KCl should be added when KFT normalizes. So the blood urea is raised because the child is dehydrated. Once you give adequate fluids to the child and the urea normalizes, then only you add KCl. This is a very important point. If this option is not there, ringer lactate is there, then you will mark that as the answer. The surgery, you know, is a Ramsted's pyloromyotomy. The surgery, you know, is a Ramsted's pyloromyotomy. And Ramsted's pyloromyotomy, if it's an uneventful surgery, then you can start feeding the child as soon as 6 hours after surgery. So very common scenario, you should know all about idiopathic hypertrophic pyloric stenosis. This was a similar case which I had encountered when I was a postgraduate. I mean, that's the worst gunshot injury case I've seen during my residency. You have a 20-year-old boy who comes to the ER after the gunshot to the abdomen. Pulse rate is 90, BP is 100/80. On examination, dressing over the entry wound is soaked with bile. Right? Patient is conscious, oriented, and complaining of pain at the entry site. FAST scan, you know, FAST is focused abdominal sonogram in trauma. You do a FAST scan and it is positive for collection in the pelvis, right? So you keep it in the suprapubic region and then you look for collection in the pelvis. There is collection present there. So FAST is positive. There is a penetrating a gunshot wound and there is bile staining. Now, is CT indicated in this patient? Well, if CT is indicated only if the patient is stable, if the patient has unstable vitals, then not indicated, right? It is not indicated if there are unstable vitals. And here we pretty much know that there is a gunshot injury, there is bile staining. That means there is a perforation which has happened somewhere, which is leaking bile. So you need to operate this patient. And FAST is already positive. So the further management in this case is you are going to take up the patient for laparotomy, make the patient NPO, give IV fluids, give IV antibiotics, and rush the patient for an exploratory laparotomy, for which we will do using a midline incision. This is the X-ray. You can see that the abdomen is studded with the pellets from the gunshot injury. You open up the abdomen and you find that there are 4 perforations in the mid-ileum region within 2 feet of each other, and there is 1 perforation in the sigmoid colon, right? 4 in the ileum, 1 in the sigmoid colon. How do we proceed now? So the 4 perforations in the ileum are close by within 2 feet. So ileal segment, we will do resection and anastomosis because they are within 2 feet of ileum. If you remove, not much is going to be affected. So you can easily do a resection and anastomosis there. For the sigmoid, if it's a clean wound, not much necrosis is there, then you can repair. But in such a case, when there is a lot of contamination, already there are 4 perforations in the ileum, patient has a gunshot injury, unhealthy conditions, unhealthy bowel. In this case, it would be better that we carry out a Hartmann's procedure, or we repair and do a proximal colostomy. And we do a proximal colostomy to save that repair, so that fecal matter doesn't come down and contaminate our repair. Hartmann's procedure has been asked multiple times in the exam. You know, if this is the sigmoid colon and this is the perforation, Hartmann's is when you cut here, you take out the proximal end as a colostomy. And you close the distal end and you keep it inside. Once the patient recovers, you can anastomose the 2 ends. Do all pellets need to be removed? No. You don't need to remove all the pellets. Whatever you remove, of course, you hand them over for medical legal purposes, but you don't need to search each and every pellet. Even if they're there, not causing any harm, nothing is to be done. So that's how you would manage such a case. Now, the same patient in the post-operative period, patient's vitals are stable, but the patient hasn't passed flatus till post-operative day 3. And the case was done by the 3rd year postgraduate, who's the final year postgraduate. Now, the postgraduate is getting really anxious about this because he's not hearing now the 3rd year postgraduate is getting really anxious because you know that flatus is like music to a surgery resident's ear, but he is not hearing that in this patient, getting really anxious. You are the intern. You tell him that, the X-ray has been done. There's distended bowel, but gas is going right down till the colon. So there is no dynamic obstruction, but bowel sounds are not heard. Right? Bowel sounds are not heard. So what is the patient suffering from? The patient is suffering from paralytic ileus. If extensive surgery has been done, there can be paralytic ileus. The postgraduate asks you what is the most common metabolic abnormality which can give rise to this. And this has been asked many times in the exam. It is hypokalemia. You correct this and the bowel starts moving. Uremia is another one which can give rise to this. So always check the kidney function tests as well. The next scenario is a 45-year-old lady who's come to the emergency room with severe right upper abdominal pain. Patient has come with right upper abdominal pain associated with nausea and vomiting since 48 hours. Examination, there's tenderness in the right hypochondrium, and she complains of a similar episode 2 months back. So again, a no-brainer, right hypochondrial pain, nausea, vomiting, similar episode 2 months back. What is your clinical suspicion? You're thinking about acute cholecystitis. So acute cholecystitis, 48 hours since the symptoms started. The investigation of choice is an ultrasound for cholecystitis and for cholelithiasis. The lady has already had 1 episode in the past. So now the ultrasound features would be of chronic cholecystitis, or to be very precise, acute on chronic cholecystitis. And In chronic cholecystitis, you can see the WES sign, the wall echo shadow sign. So the wall is echogenic and it is thick. So thickened wall, you will have a thickened wall. The stone is going to be there and it is going to cast a post-acoustic shadow. You know, stones cast a post-acoustic shadow. Whereas if you had a polyp will not cast a post-acoustic shadow, but stones always cast a post-acoustic shadow. So you get the WS sign in chronic cholecystitis. Now, how do we proceed? You know that if patient comes, so how do we proceed? You should always go stepwise. As I've been telling you, make the patient nil per oral, give IV fluids, give IV antibiotics, give painkillers to this patient. Okay. And you know that if the patient comes within 3 to 4 days, according to Tokyo classification now, within 3 to 4 days, you can perform emergency cholecystectomy. So we can do emergency cholecystectomy in these patients, and you need not do an open surgery. You can even perform a lap emergency cholecystectomy. That's also an acceptable option in the emergency scenario as well. So the patient gives consent for the emergency surgery and you perform the emergency lap cholecystectomy. On the second day of the surgery, unfortunately, the patient develops sudden right upper abdominal pain and the patient is jaundiced and febrile. Now what do you suspect? This scenario has also been asked in the exam. Post-cholecystectomy, right upper abdominal pain, jaundice and fever. So we are suspecting a leak. You do an ultrasound. There is a collection in the right hypochondrium. So that further tells you that there is a leak post-surgery. What are we suspecting? We are suspecting a leak post-surgery. How would you confirm the diagnosis? So normally speaking, we would do an MRCP to confirm the diagnosis or an ERCP. Now MRCP will tell us about the leak and location, but MRCP is magnetic resonance cholangiopancreatography. Magnetic resonance cholangiopancreatography. You can't do an intervention, right? ERCP will tell me about the leak and it will tell me about the location and we can intervene as well. Intervention can also be done. So this is a debatable issue, but most gastroenterologists tend to prefer doing an ERCP. If not, you can do an MRCP to confirm the diagnosis. This was asked in the INI CET exam. You should know that the Bismuth and the Strasbourg classifications for bile leak. You should know the details for the Bismuth and the Strasbourg classification for bile leak. This was asked in the exam. They had asked about an aberrant duct leak. You should know both the classifications in detail. I've covered them in the gallbladder module as well. Now, the patient has a leak. It's just been 48 hours. So we have discussed previously as well that if the patient is within 2 to 3 days, there is a leak, you can reoperate and repair, and T-tube can be inserted. You know, T-tube I've covered in detail in the module. You should know about T-tube. So you can put in a T-tube and repair. But it is after 3 days, then the tissue is inflamed and the sutures will not hold. The sutures will just not hold because the tissue would be so inflamed. Then here we will do an ERCP and I will do stenting and I will put in a pigtail catheter for the collection. So this question has also been asked in the AIIMS exam. You put in a pigtail catheter to drain that biloma, which is there, the bilioma, and you do an ERCP, that is endoscopic retrograde cholangiopancreaticography, and you do stenting to prevent the leak. So these were 10 scenarios which I wanted to discuss with you. These are the ones which are commonly asked in the exam. So this module is very important from your entrance point of view. Always, I want you to think about the keywords, analyze. Now, this is very important from the entrance point of view. And as I've told you, please focus on the keywords, because they are the ones which would help you diagnose the condition early, right? And abdomen, you know, is a Pandora's box. You never know what surprises it throws at you. But again, if your concepts and your theory is clear, you can identify these keywords. You can easily identify these questions in the exam. This is one of the cases which I will never forget in my life. This is what I've termed as Metalloman. And this was a boy who used to eat metallic objects. And there were two high-powered magnets which were keeping all these metallic objects in his ileum. Unfortunately, when he stopped eating them, that's when he developed a perforation. And when I operated this patient, almost 600 metallic objects were found. But what I want to tell you is that abdomen will always keep on throwing surprises at you. But if your concepts are clear, you can answer these questions easily. Thank you.